Okay, I'm going to press start webinar and wait about that long minute or less if you want. Thank you.
Okay. Let's stay alive with the wait. Okie doke, I guess we'll go ahead and finally get started here. So I'm Eric Busse. My partners, Dr. Jacob Ziegler and Robert Frieder here. Myself and Dr. Ziegler are adult reconstruction surgeons. It simply means we perform hip and knee replacements and then revisions of hip and knee replacements. And Dr. Fried has expertise in sports medicine with subspecialty training in shoulder reconstruction. He does a lot of shoulder replacements. So we're here at the orthopedic surgery, Mankato, Mayo Clinic Health System pain and joint replacement seminar. So we don't have anything to disclose today. So the orthopedics department has been going through some expansion lately. This is a picture from a few years ago. Dr. Foley, Dr. Fried, and Dr. Corona, front row center there with the ribbon cutting ceremony on our new clinic, which has allowed us to expand by leaps and bounds over the past few years here locally. These are the number of the providers here today who kind of support our role in orthopedic surgery in Southwest Minnesota. There's more than 20 providers on this list, and all walks of orthopedic surgery are represented here locally, other than spine surgery, which is represented by our neurosurgery colleagues. And then orthopedic oncology, that's a referral to the folks at large academic centers. Primarily, we have 3 folks now in Rochester for orthopedic oncology. So lots of folks here locally to help. These are the people here in Mankato. So we've got Dr. Foley, Dr. Fried, who's present tonight, Dr. Ziegler, myself, Dr. Harris, who performs surgery of the hand as well as plastic reconstructive surgery, Dr. Hendel with expertise in sports medicine, Dr. Corona is a hand surgeon, Dr. Taylor Beers, he is the only foot and ankle surgeon between the Twin Cities down to Sioux Falls, Des Moines, and Rochester. So very lucky to have Dr. Beers with his expertise here. Dr. Madsen with specialty in podiatric care, and Dr. Wade Johnson, who performs non-operative sports medicine with a lot of injections. And he also provides some spine care as well. Non-operative spine care. These are our orthopedic APPs. We've got a one-to-one pairing here in the office. So frequently when you see a surgeon or doctor locally and have surgery, these are our team members who are paired up with us, performing a lot of assistance in the operating room as well as on the surgical wards if someone does stay in the hospital overnight. These are folks up in New Prague. We've got Stephanie Kvass. She works in podiatry. She's full-time there. Dr. Foley, Dr. Hendel, and Dr. Ziegler have been performing outreach there. And they're also in the process of hiring 3 orthopedic surgeons up there. One is Dr. Neil Olmscheid. He actually just started in New Prague, and 2 more are planning to start within the next, I think, year and a half. That's Dr. Mike Stewart and Dr. Brad Kruckerberg should be up there within the next 2 years. These are folks down in Fairmont on the, I guess that's the left side of the screen there. Dr. Stephen Berthelsen recently announced his retirement. He's hanging up the cleats on October 1st, actually, after many, many years of service, not only in Fairmont, but also overseas in Costa Rica. After a long career, it'll be sad to see Dr. Berthelsen go, and that'll be big shoes to fill. Currently, Dr. Wickenheiser with his team, Sarah Snyder, who also splits time between Dr. Wickenheiser and Matt Weber, providing care down in Fairmont. So very, very, very wonderful team locally. So over the past year, what have we done here? We've had to do a lot to navigate the COVID-19 pandemic. You know, as soon as the worldwide pandemic became a problem locally, we really had to restrict a lot of access to the hospital. We dealt with a lot of bed shortages. During this time, we were planning expanding our department into New Prague. We've also got a bone health clinic, which is run by Jared Torkelson. He's got a number of years of experience here and has done a great job, you know, working on folks who have osteopenia, osteoporosis, as well as associated fractures. We've opened up a walk-in clinic, which is open 5 days a week for folks who come in with either you know, kind of minor care. It tends to be things like sprains or you know, minor fractures that don't require hospitalization. Then we've also begun performing total joint replacement on an outpatient basis. So things that were almost unheard of locally before, during the pandemic, we did have a lot of growth, and Becca Father is sitting in back of the room. She's been a critical part of being able to perform hip and knee replacements and send people home the same day. Thank you, Becca. And then the final thing that we've begun here is use of robotic navigation or assistance to perform hip and knee replacements. We'll have a little kind of spiel on that as we get in here. I guess I have some animation. So the walk-in clinic, this again, Monday through Friday, 8 to 4. This is staffed by an advanced practitioner provider, as well as an orthopedic surgeon, for more of these minor yet acute things that don't necessarily require someone going to the emergency room. This is a picture of the Mako robot. This device allows us to be, you kind of reduce outliers in radiographically on total hips and total knees. They are furthering this device with advancements in shoulder replacement surgery, not quite available locally yet. And then there are a number of other robotic assisted tools that we've been exploring here. The first and foremost is this one, the Stryker Mako, which is what we use locally. What's the, you know, what does the future holds? We don't necessarily know quite yet, but it probably will involve some form of robotic assisted or robotic navigated joint replacement surgery. This is some of our data on same day total joints. Again, Becca has absolutely been critical of this. We could not do it without her. And the graph here shows we were, you know, none of our total joint replacements were going home same day in 2019. And over the past year or so, you can see we've really been ramping up this number to about somewhere between 30 to 50% of our joint replacements on any given month are able to go home successfully that same day. So that involves a lot of work by many different team members, not only, you know, surgery in the morning or as early as we can get started, but also involves, you know, revamping our care from an anesthetic standpoint. Physical therapists are now involved working in the recovery ward, as well as our nursing staff in the recovery ward. A lot more people remain there during the day to receive this care and able to go home the same day. So this has been a nice project we've been working on growing through the practice. So kind of the meat and potatoes of what we're going to talk about here tonight, after a little plug for what we can do locally. I just review some common orthopedic complaints and problems, go through some of these more conservative things that you can do at home on your own prior to seeking care with a physician, or something you can collaborate with your primary care provider in discussing. And then what we do here is kind of surgical interventions for some of these problems. So orthopedic surgery is the surgical treatment of disorders of the musculoskeletal system. And locally, again, our neurosurgery colleagues perform care in spine. That is a big crossover between orthopedic surgery and neurosurgery. Or locally, our neurosurgery colleagues perform spine care. But here we do a lot of hip replacements, knee replacements, shoulder, as well as hand surgery. And then in addition to this, if someone has a broken bone or a fracture, we can take care of that locally too. So back pain is the most common cause of disability worldwide. More than 80% of adults experience some form of debilitating back pain that will take them out of work at some point in their lives. The good news is that 90% of cases improve with conservative modalities, things like physical therapy, non-steroidal anti-inflammatories, ibuprofen, Aleve, Advil, that sort of thing. And they can also be managed by our physical medicine colleagues, Dr. Doffenbach locally, pain medicine, and then, like I mentioned before, the neurosurgeons here when it does come to require surgical treatment. So again, things like non-steroidal anti-inflammatories, physical therapy, exercise, and stretching is very important, especially the posterior extensor structures like the hamstrings. Weight loss is important, and limiting alcohol and tobacco use. And this is kind of an important comment that current clinical practice guidelines do recommend a full 6 to 8 week course of physical therapy with medication, non-narcotic medication, mind you, prior to doing any advanced imaging like MRI or CT scan, unless someone has evidence of a specific neurologic problem that requires urgent surgery. And those are very rare and uncommon. It's kind of beyond the scope of this practice, but things are, or someone might experience a permanent nerve problem. Those are folks who go to surgery early before any of this. And we call those red flag symptoms. All orthopedic practitioners and most general practitioners do know how to ask for those red flag symptoms if they occur. So it's kind of a discussion between you and your doctor. And sometimes even physical therapists too are very well versed in those. So other causes of back pain, most of the time it's myofascial, or the muscles around the back. A compression fracture associated with osteoporosis is very, very common. And then you can have referred pain from other joint systems or organs. Pain from the hip is very commonly referred into the spine and vice versa. And then some of these intrinsic spinal disorders, we call it nerve root impingement, or you may have heard of someone who has a slip disc that can pinch a nerve root, which people experience burning. That typically goes all the way down into the leg or into the fingertips. People can have degenerative disease of the spine. You can have degenerative scoliosis. You can have a fracture. And then the other thing at the bottom, there are a whole series of diseases we call inflammatory spondyloarthropathies. It's a fancy term for sometimes the immune system can affect the spine. So this is a case that we've got. This is one of my patients, and these red arrows are pointing to a severe degenerative disc disease at the base of his spine with an associated slippage of that L5 vertebral body relative to the sacrum, as well as the next segment above, which is the L4. This is called spondylolisthesis. We call it a spondy for short. That's just a slang term. But that just means that the vertebral bodies are slipping relative to each other. And this can impinge on the nerves that are exiting on the posterior elements of the spine. This gentleman, you can see at the top of the screen there, underwent decompression with a spinal fusion. This was done by our colleagues in neurosurgery, Dr. Megan Murphy. Did a wonderful job with this gentleman. And then you can see further down on the x-rays, he's got 2 hips there that show pretty advanced collapse of the joint space of that ball and socket joint, pretty severe osteoarthritis of the hips. So after his spine was taken care of and fused and fixed, he underwent staged bilateral total hip arthroplasties. And this was a gentleman who was into his 80s, and he was still able to go duck hunting with his sons, which is something that was quite important to him. So after all this work, he was able to get out and do some of the things he really wanted to do. So moving on a little bit, so that was kind of the crossover, hip and spine. Moving on to hip pain. So if someone points kind of in the groin crease directly posteriorly, directly from the front back, that's where the hip is located. So oftentimes when true pathology from the hip is present, folks tend to say, oh, it's actually my groin that hurts. And that's actually where the hip is. You can see this person kind of putting their hand in a C sign and placing it on the hip. They oftentimes have a C sign distribution around the hip. They can exhibit a Trendelenburg gait, where when they stand on the leg that's affected, the pelvis drops and they actually have to lean towards that hip to walk. And they kind of exhibit this gait where they kind of walk like a penguin. It's unfortunately what a lot of folks say when but that's called a Trendelenburg gait. Pretty common to have difficulty with shoes and socks as this gets more advanced. And again, pain from the hip commonly goes into the knee, but rarely into the foot. If that's the case, oftentimes we look for another, what we call extrinsic cause, something like a pinched nerve higher up in the back. So causes of hip pain can be multifactorial. Sometimes people have arthritis of the spine as well as the knee that's presenting as hip pain, and we don't necessarily find anything there. They can have bursitis or inflammation of the tissue around the hip. There is a whole series of patients who exhibit what we call FAI, or femoral acetabular impingement. Those generally tend to be folks who are kind of athletes in their youth and develop hip problems early, things like soccer and hockey players, or folks who are very flexible, like gymnasts and dancers, can have difficulty with their hips. When someone has a hernia, that can have referred pain down into the groin, which can be a little bit confusing sometimes when you experience that. You can have a sensory nerve can get pitched from something like tight pants or tight belt buckle. Tendinitis can occur around the hip. These inflammatory arthropathies, where it says arthritis, degenerative arthritis is by far the most common that we see in our practice, where the hip wears out with time. Folks can have rheumatoid arthritis, which is an inflammatory disease where the immune system starts to destroy the joints. This is also associated with that occurring earlier in life. They called JRA, or juvenile rheumatoid arthritis for short. Medications, as well as alcohol use and other things, can affect the blood supply to the hip, which we call avascular necrosis. And that happens because the blood supply to the hip comes from around the femoral neck and goes in a retrograde fashion up to the ball. We see this much more than we'd like to, where young patients can have severe hip problems from this phenomenon of avascular necrosis. And then probably one of the most common causes for hip replacement or partial hip replacement nowadays is a fracture. As our population ages, it is associated with a higher incidence of decrease in bone density, osteoporosis or osteopenia, and people very common to have hip fractures later in life. So again, generally we start with conservative treatment. Again, non-steroidal anti-inflammatories, physical therapy. Some folks can have surgery and they use a cane or a walker. And a corticosteroid injection is a very useful thing to sometimes diagnose exactly where is the pain coming from. Is it referred pain from the spine, or is it directly from the hip? And a diagnostic hip injection, we call them, is what's demonstrated by that picture. It can be a very useful tool to determine how much of your pain would be controlled after a total hip arthroplasty or a hip replacement. Weight loss is a very useful modality to decrease risk before surgery or improve pain prior. And exercise and pool therapy is a very useful thing because it allows us to take the body weight off the joints and still get a good cardiovascular workout to help lose weight. This is demonstrating someone who's got a labral tear. That's what the black and white, or the dark image demonstrates an MRI of someone with a tear in the labrum, which is a ring of tissue around the joint. And then this picture on the left is demonstrating a hip arthroscopy, which is a more conservative measure, generally reserved for younger people if they have a problem with the labrum or that ring of tissue that serves around the socket of the joint. Surgical treatment, this is primarily what myself and Dr. Ziegler do, hip replacement. This is a gentleman who had pretty severe osteoarthritis of the hips, and we performed staged bilateral total hip arthroplasties in shoe surgery fashion. And this is a gentleman who had a long spinal fusion prior to hip replacement surgery. So you can see his long fusion segments on the left side of the screen. And then underneath that on the right, he had pretty severe osteoarthritis of the hips and required a hip replacement or total hip arthroplasty. Now, this has been demonstrated statistically to increase his risk for dislocation. So we utilized a special bearing surface, or we call it a dual mobility liner, which has been shown to decrease the risk for dislocation in folks like this and with other problems. What that serves to do is increase the distance where this femoral neck impinges on the edge of the socket before it levers out. So it's a very useful tool to prevent something like that. And then this is a young gal. She was actually in her 40s. She was involved in a pretty horrific car accident where her knee struck the dashboard, and the hip not only was associated with a dislocation, but also a fracture of the wall of the socket. And she had undergone surgery several years ago at an outside facility and since moved to Minnesota. And then because the joint surface was totally obliterated and the femoral head had died off, we performed a hip replacement where we left most of that hardware intact because that's put on from the exterior surface of the socket. And we were able to perform a hip replacement in this individual. She's doing quite well today. So that's my plug for hip pain and kind of the department. Let me introduce Dr. Ziegler, who's going to talk about kind of knee pain.
Thank you. Thanks, Dr. Busse. So we'll move on. We'll keep moving, kind of working our way down here. So common presentations for knee pain. Folks will have pain in the, what we call the anterior, the medial. It's kind of just the front, the inside. Sometimes it'll be all over. Sometimes folks will feel it more in the back. And then sometimes folks will feel that it's sort of unstable or that it'll want to frequently buckle or give way. How you kind of tackle it depends a lot on where a lot of those symptoms are being felt and kind of what the issue being noticed and felt is. So things that can cause, when we kind of break them down into intrinsic, so things in the inside of the knee itself, the knee's walled off by a capsule tissue. And so if it's in the inner part of the knee itself, it can be things like a torn meniscus. That's there's two meniscus in each knee, one on the inside, one on the outside. They're a force distribution cartilage. They kind of help spread the force out, give a little bit of stability. That's a common problem for folks to have, where either they may have a healthy knee and get tackled playing football or doing some activity or twist their knee and tear it that way. Or a lot of them, and a lot of the ones that I see are just ones that sort of come about as the knee is on its way to starting to wear out. Ligament injuries, such as the ACL or the PCL, those are in the insides. Those are the ones in the center of the knee that crisscross. People can get injuries where those get torn. That'll cause instability of the knee. Collateral ligaments, those are the ones on the MCL and the LCL. Those are the ones on the inside and the outside part of the knee. They give side-to-side stability to the knee. And so oftentimes a buckling or injury to the knee will rule out in that. That avascular necrosis that Dr. Busse mentioned in the hip, less common in the knee, but is something that we'll see, where an injury to the blood flow to the bone that supports the cartilage, the smooth gliding surface, can get disrupted either from an injury or different medical conditions. And that can cause some of that bone to temporarily die off and can get soft and weak. And then finally, arthritis, which can fall into either just general wear and tear, osteoarthritis, or an inflammatory type of arthritis, such as rheumatoid arthritis or a few other inflammatory symptoms. Then there's extrinsic problems. Those are ones really still around the knee, but outside the knee itself. So there's a lot of bursitis and tendonitis type of things, something called iliotibial band syndrome. That's a big, long band of tissue, comes all the way up from the side of your hip, all the way down the outside of your knee. Very common both in young folks doing a lot of athletic events, as well as we just go through life. And sometimes even after people have had knee replacements, that can still flare up and be irritation. Referred pain from the hip, as Dr. Busse mentioned, particularly in our kids, when we see our pediatric patients, as we teach our residents, and we have a lot of various students that come through, and we always teach them, one of the first things, if you're seeing a kid with knee pain, you got to first and foremost make sure they don't have a hip pathology. We do see that in adults too, where it'll be coming down from the hip. And then foot problems contributing to gait abnormalities and even just uneven loading on the knee. So as Dr. Busse's mentioned, frequently we start with the least kind of aggressive treatments that we can. So ibuprofen, Aleve, Tylenol, things like that. Sometimes, particularly for some of those bursitis and other things, there's a good role for physical therapy. We can get a lot of people better just with those things. Assist devices, canes, walkers, things like that, depending on the individual. Corticosteroid injections are a frequent good option in the knee in particular. Usually tell folks it'll get some relief. It's just a matter of predicting and trying to sort out how long and how much. There are a few other injections around the knee we can do. Viscosupplementation or hyaluronic acid, commonly called kind of the rooster comb injections, have a role. And there is a procedure our interventional pain specialist does called radio frequency ablation around the knee. Actually, just now, I think recently started doing it around the shoulder, occasionally around the hip, and they've been doing it around the spine for many years. Weight loss factors in a lot. I talk to patients and tell folks, depending on the activity, 6 to 9 times body weight goes across the knee. So every 1 pound you're able to take off, that's 6 to 9 less, depending on what you're doing, that the knee feels. So it adds up in a hurry. And hopefully folks find that encouraging to know that every bit makes a difference. And again, as mentioned before, pool therapy is a wonderful way to really take the load off the joint, but to get a very good exercise, whether you're just walking laps or swimming or whatever it may be. It's a good way of doing things. The role for surgery varies. There's everything from our arthroscopic surgeries, as this is very nicely depicting. That's sort of a keyhole surgery. We make some very small incisions over the front of the knee and on the sides and put in a camera and some really long instruments. Here we see on the other side of the screen a torn meniscus, and we can go in and just sort of trim back that unstable flap. Sometimes meniscus tears are what we call repairable, where we can put in some sutures to sort of tack them back and stabilize them back down. Able to do a lot of our arthroscopic assisted surgeries with like ligament reconstructions and a lot of things that way. Here, a number of us do a number of what we call cartilage preservation type of surgeries, and we'll do a lot of that as arthroscopic as you can. At some point, you usually do have to do a little bit bigger incision, but it allows us if there's just a pothole of injury to the surface cartilage, this articular cartilage, we can sometimes do some things to sort of fill that pothole, if you will, and otherwise keep the rest of the knee. All the way up to here, what this is showing us is knee replacement surgery. And so ultimately, if that articular cartilage, that surface, that cushion, that's the smooth gliding cushion, is too worn out that we're not just filling a pothole, then you get through all the non-surgical things, then really doing a resurfacing of that whole joint with what we call a joint replacement or a knee replacement is really our best way to go. And what you see on that is you resurface the end of the thigh bone with a metal, a cobalt chrome surface there, the top of the shin bone, usually with a metal area. And then there's a space in between there that's not empty. On the shin bone side, on the tibia, there's a locked in polyethylene piece there. So the metals never touch, but you get a nice smooth surface again. The complexity of this goes where Dr. Busse and myself do what we call revision or redo knee replacements. This is a picture showing a loose recalled implant done elsewhere, and eventually that wore out and that implant started to loosen and became quite painful for this individual. So we were able to take off that worn out implant that wasn't performing well and was causing a lot of pain. And then we redid that and rebuilt the knee with some of our more modern revision tools, anchoring a stem above and below in the bone there, and then getting a solid new surface on that knee. We are able to do knee replacements and things when that cartilage surface is injured and disrupted from fracture. So here was a very unusual type of fracture. We fix a lot of the fractures that go through the joint surface, but some of them are really not amenable to that type of fixation and things. And this was one of them. So the best option in this one for this person was to just sort of rebuild that surface all anew. And you can see here, the injury and the fracture was on the shin bone on the tibial side down here. So we rebuilt a new surface, stable platform with our metal and the polyethylene, and gave this person a new solid knee to continue walking around on. Management of progressive and more severe, deformity, and what that means is just curve or unusual shape and changes to the bones and to the knee. can be managed with more and more complex type of joint replacements. So again, here, this one was rebuilt with a little step to build that up and to really straighten that leg out and rebuild a stable, solid knee for that person to be able to walk around, bend, squat, and do all their regular activities on. On occasion, there's been previous broken bones that were fixed, and if for some reason they don't go on to heal. So here was what we call a distal femur. So the end of the thigh bone had broken. It was initially fixed with a plate and screw construct to try and straighten things out. But unfortunately, that just really, the ends of those bones never went on to knit back together. So to salvage that and to give this person, again, a leg that they can walk around and do normal functional activities on, we resect that broken bone that didn't heal back together, anchor with a stem higher up in that thigh bone, and then rebuild a knee replacement onto that. So we'll move on, and I'll turn things over to Dr. Freed, one of our orthopedic surgeons who does lower extremity joint replacement, as well as a lot of special focus on shoulder.
Thanks, Dr. Ziegler. All right, so yeah, I'm going to talk a little bit about shoulder pain. A lot of what I'm going to say is just kind of piggybacking on what Dr. Ziegler and Dr. Busse talked about. And so I'd like to kind of break down the causes of the shoulder pain, big categories here. Musculoskeletal, you're kind of the run of the mill that you think about: muscle strains, tendon tears, fractures. Neurologic, with that category, we're thinking up higher up, maybe from the neck. Vascular are a few things that will give you some trouble that feels like it's coming from your shoulder, but it's indeed a more vascular or blood-related reason for that pain. And other is a broad category, and sometimes that even includes tumors. And so, again, similar to the hip and the knee, pain can come from two different places. The intrinsic pain typically means it's coming from the shoulder itself. Tendon tears, tendinitis, anything to do with that rotator cuff. The labrum, which is a ring of cartilage that surrounds the shoulder joint that kind of deepens it, gives you some stability that can tear, particularly with trauma or shoulder dislocations. Impingement, if there's some bone spurs and you're reaching up and overhead on a regular basis. Over time, that pinching or that impingement can give you trouble. Of course, arthritis, as I mentioned, fractures or trauma-like dislocations. Sometimes we can have frozen shoulder. Oftentimes frozen shoulder, we really don't have a good reason for it. It just kind of comes on, and over time it goes away. Infection and then tumors around the shoulder can give you that pain. Extrinsic pain, as I mentioned, means it's coming from somewhere else. Often with the shoulder, there is crossover between neck pain and shoulder pain. So we're thinking about something coming from the cervical spine up higher. Shingles, it's a common area to have a flare or one of these shingles outbreaks around the shoulder, and before you even see the rash or the vesicles, you think it's coming from the shoulder, but it's not. Blood clots, thoracic outlet syndrome, those are some of the vascular issues I mentioned. Pneumonia can refer to the shoulder, and even just having poor posture. Some of those ergonomic things that you just bring your shoulders forward over time, that can give you some trouble. So those are kind of the big two categories of what can give your shoulder. So a lot of times when we're thinking shoulder, we want to know what's going on, how is it behaving, what makes it better, what makes it worse. So location, is it coming from the neck? Is it going down the arm? Oftentimes shoulder pain will refer down the arm to the elbow a little bit, but it typically will not go down into the wrist and hand. Again, if it is, we're thinking something higher up, particularly in the neck. Is it a sharp pain? Is it a deep pain? Is it something that wakes you up at night? These are all different characters that we're asking. If we were to visit with you in the office, associated symptoms, what else is going on? Do you have that numbness down into your hand? Is the shoulder pain on both sides? And those are questions. And then, as I mentioned, what makes it better? What makes it worse? Easy. A very common theme here amongst these slides. Mainstay, the first line of treatment is always conservative, the non-operative treatment. Shoulder pain, really any of those, any of those reasons, anti-inflammatories may be of benefit. Aleve, naproxen, Advil, your Motrin, those sorts of things are often used. Physical therapy, again, for all of those reasons, intrinsic and extrinsic, but partial tendon tears, tendonitis, arthritis. Physical therapy is quite helpful. Occasionally we'll use injections in the shoulder. And then just having that home exercise program. You go to physical therapy, but you need to continue that at home. And so we really focus on continuing those strengthening exercises at home on a very regular basis. I don't know why I keep hitting. So if you do fail that non-operative treatment, what are we looking at? One of the procedures is an arthroscopic procedure, as Dr. Ziegler talked about. There are certain conditions that we can address quite nicely through a poke hole surgery. Rotator cuff tears that are amenable to fixation, we can oftentimes fix that arthroscopically. If you have that impingement or that bone spur, we can go in there and we have a little burr, almost like a little Dremel tool that can just kind of shave away any prominent little areas of arthritis or these bone spurs. In a similar fashion, as I kind of go up the list there, distal clavicle resection, if you have a little arthritis in that top AC joint above your shoulder joint, sometimes just with certain activities, physical labor, that little area can be shaved out. And then I'm apparently going up backwards here, but bony stabilization procedures, those shoulder dislocations, again, if you do seem to fail that non-operative treatment, it is quite amenable to stabilizing that arthroscopically. And so this is operative photos of a shoulder. On the left there is a lateral or kind of a side view of the rotator cuff. And what we're looking at is the tear, that white tissue above it is the rotator cuff, the muscle we call the supraspinatus. And that's supposed to be coming over and attaching over to the bone. And you can see, maybe appreciate how that's kind of lifting up there. We do have our cursors up there. And so that's the edge of the tendon, and it is really supposed to attach way over here. So it's not only torn and fully torn, but it's starting to retract or pull back. Oftentimes our discussion with rotator cuff tears relates to the retraction of the tendon. And as you think of it as a rubber band that's under tension, and if you cut that rubber band, it will start to spring back. And then in another, use of words, it's a use it or lose it. So if that thing sits retracted, pulled back and not attached, the muscle starts to atrophy. And then at that point, we start to have less favorable outcomes if we were to go back in and try to fix it. So these full thickness tears, we have a shorter or smaller threshold to fixing it. But how we often address these, we put these little anchors in the bone. They're almost like little drywall anchors you use to hang a photo or a picture in your home. And in these little anchors are sutures that come up out of it. And we pass those with a special device through the tendon. And then we, on the right image on the screen there, we use those sutures, and we create this crisscross pattern. And it essentially reduces that tendon and pushes it down to the bone to create a nice healing bed for it to try to heal and essentially become the return of normal function. We call it a double row fixation, meaning that we have anchors in two different spots, and it really compresses that tendon back down. Now, the procedure itself is not a terribly long procedure, but it is a long recovery because we're trying to get tendon to heal back down to bone. But it's a little bit of a lengthy recovery, but we have pretty good results if we can get to it on a timely basis. More of a bony condition that we've kind of been talking about, arthritis. And this is a progressive thing, kind of a wear and tear, but strong genetic component with the osteoarthritis, kind of that run of the mill. You also, just like the hip and knee, have an inflammatory arthritis, like a rheumatoid arthritis. And, oftentimes in the shoulder, we don't walk on our shoulder. And so oftentimes people come in a little bit later than they would maybe with the hip or knee. And what I'm showing here on the left screen with the red arrows is how narrow that joint space is. This individual is essentially bone-on-bone arthritis. And the yellow arrow is showing a large bone spur that's kind of projecting down into the axillary pouch, kind of down in the armpit. And so this is what we would consider end-stage osteoarthritis. And one of the ways that we would address this, particularly in younger, healthier, and more active individuals, is a total shoulder replacement. And in this case, an anatomic total shoulder replacement. And anatomic meaning it's kind of the regular, it's the taking out, or we're putting in exactly what we're taking out. So we replace the ball with a metal ball and the cup with a plastic cup. And this, again, particular implant, it's a stemless implant. And so we really don't have to go all the way down into the humerus with a longer stem if the bone quality up top is of adequate stability. And then just opposite, and you can't see it, there is a plastic ball bearing right here, and there's that little white line that just shows that it's in place. And in this situation, this looks pretty good, but this would be pretty typical procedure for someone with end-stage osteoarthritis that has, just like the rotator cuff, failed that non-operative treatment. We also will replace shoulders for other reasons. In this individual, it's a fracture to the top part of your humerus bone, or we call it proximal humerus fracture. And the arrows are kind of pointing out all these different fracture fragments. Now, when we have multiple little fracture fragments and they're all kind of displaced or shifted or moved around, the healing capacity is a little bit less. Now, in the vast majority of people, they do okay, but in other people, the displacement of that shifting of it is so significant that function is a bit of a concern. But at the same time, going in there with plate and screws is just not going to be quite adequate enough. And so in that case, we do have a procedure where we can just replace that with a shoulder replacement arthroplasty called a reverse shoulder arthroplasty. And so you can see on the right image there, instead of the ball being on the bottom and the cup up top, now we're swapping that or reversing it. And what this does is it takes the rotator cuff out of the path, out of the equation. And so in a fracture where the bones might just erode away or absorb, or if the rotator cuff was injured, either be prior surgeries or in this case, like a fracture, this takes it out of the equation. And so you should have a well-functioning shoulder despite that. And this works really well in quite advanced arthritis where bone quality is a major concern. So I'll kind of wrap up our talk here. Dr. Busse kind of talked a little bit about some of the broad categories, but back and joint pain is very, very common. There's many different treatment options for every joint or every, back pain you come in. But initially, and almost always conservative management is the best route. And once you kind of go through that and you're really not getting the outcomes that you want or what you think is best, we do have some tools in our belt, and it's oftentimes the surgical treatment is what's necessary. And today we kind of talked about joint replacement being kind of that main one for that end stage arthritis. But I just want to point out again that here in Mankato, we really have someone you're just meeting 3 of us here, but there's somebody that really can address most any of your joint or musculoskeletal or orthopedic complaint. But I think that kind of wraps it up. I know we have some online questions. Any questions here from the in-person crowd, or sure are welcome. You can direct any or all towards any one of us. I think we can kind of answer it, but I think, Eric, are you seeing the online ones or something? I didn't see that once. Okay.
Some of these online ones will take the next weekend.
Are there ones you want to read out or?
Was asked about robotic. Who uses robotics? Why they use robotics? Sure. Yeah.
So did you write out an answer? Do you want to just say it? Because there might be people there. She might be able to hear it.
Go ahead. Yeah. So there was a question about utilization of robotic navigation. Just said, do you use a robot for your procedures? And all the providers here who do hip and knee replacements do use robotic navigation in certain instances. We don't necessarily have to do so for every individual. So we kind of take it on a case-by-case basis. Another question was, do I have to stay overnight after joint replacement surgery? And the numbers are always changing. What we showed are we're kind of increasing to the number of about 50% up to on a month-to-month basis are able to go home the same day. I'd say maybe 5 to 10% of people stay more than one night and require doing something like going to a nursing home afterwards. So it's more common. Folks are either going home the same day or the next day after hip or knee replacement and shoulder replacement as well.
It's kind of, so most people that stay overnight still are technically outpatient joint replacement.
Oh, yeah.
Big distinction is that we're talking specifically about having your surgery in the morning, going home that afternoon.
Yeah, Dr. Ziegler makes a good point. When we talk about some of the rules for insurance purposes, they kind of quantify an outpatient stay as less than 23 hours or something like that. So once we put all that together, then 90% of our folks are going home pretty quickly. So they don't necessarily meet the Medicare, Medicaid criteria for inpatient admission.
Doesn't it depend to the time of day they have the surgery?
You're exactly
It's
correct.
earlier.
Yep. So the question, does the daytime of surgery, time of day for surgery dependent, and that makes a big important point with our physical therapists. So we've kind of extended the time that they're available in recovery. But if there is a surgery that goes late for whatever reason, sometimes even though that person would qualify to go home the same day, that's not always possible if they can't get good therapy prior to leaving.
I'll have to say it's very impressive. My dad had hip surgery at Mayo way back. I think it was like 20 days. And then his second hip was 12, which we thought was wonderful. My sister had 1 day. It's been amazing to see the change. It's awesome.
A lot of coordination, a lot of groups coming together, and it's been a lot of really planning those transitions. And I think that's
Oh, much better.
good change.
I think he was only to sit up the first day in bed.
Yeah.
I mean, now, amazing.
Any other questions online at all? Feel free to type those in if you're still with us. Any other questions at all? Thank you for your comment. That's a huge change that completely different than the way we did things years and years ago. Okay, well, I guess thank you very much, everyone, for your attendance. Thank you very much for your care, everything you do. Mike and Becca, really appreciate your time here tonight. And please feel free to reach out. We do have some contact information available. If there's anything that we can do to answer questions down the line, happy to help.
Well, you in the gift bag tonight.